Welcome back to the deep dive. Today, we are opening up a file that, at first glance, looks like some pretty technical medical coursework. We're digging into an anatomy series by Dr. G.S. Raju, and we're going to be focusing specifically on his breakdown of the esophagus.
Which sounds like, standard textbook territory, right? Like something you'd just skim before an exam.
Exactly. But once you start unpacking Dr. Raju's material, you realize this isn't just memorizing parts. We're essentially going on a tour of what might be the most underappreciated high-stakes highway in the entire human body.
I mean, it's the tube that keeps us fed, a literal lifeline.
It is. And the engineering behind a simple swallow is just, it's surprisingly complex.
It really is. It's a piece of machinery we take for granted, what, maybe 600 times a day?
Mm-hmm.
We just swallow. We just assume it works.
Right. And to really set the stage for this, we have to completely shift our perspective. Dr. Raju presents all this through the lens of endoscopy. So we're not looking at a flat diagram on a wall. We are virtually standing inside the procedure suite. So imagine a patient comes in, maybe they have chronic acid reflux or
trouble swallowing, yeah.
the lights are dimmed, we're in front of the monitor, and we are about to take a tour of the body from the inside out.
And that perspective shift is so crucial. When you look at anatomy from the outside, say in a dissection, everything's static, it's frozen.
Right.
But through an endoscope, you're in a living, moving environment. You see the pulse of the heart actually pushing against the wall. You see the diaphragm squeezing. It's a dynamic place.
So our mission today is to map that entire journey. We're going to drive from the mouth all the way down to the stomach. We need to understand the geography, the incredibly crowded neighborhood it travels through.
It's a very high-rent district.
It really is. And, the microscopic architecture that keeps the whole thing from falling apart.
And most importantly, identifying the landmarks. We need to know what tells the doctor, okay, this is healthy versus, uh-oh, we have a problem here.
Okay, so before we start driving that camera down, give us the lay of the land. Where does the esophagus even fit in the big picture of the GI tract?
Right, so to understand the esophagus, you have to visualize the whole flow. The gastrointestinal tract is, functionally, it's one long continuous tube.
One single path.
Exactly. It changes shape and texture, it gets wider, narrower, but it's one path.
Yeah.
If we trace it the way Dr. Raju does, you start at the oral cavity of the mouth.
Okay.
From there, you move to the pharynx, the throat area, and then comes our star of the show, the esophagus.
The delivery chute to the stomach.
Correct. And just to complete that map, from the stomach, you go to the small intestine, then the colon, rectum, and finally the anal canal. That's the sequence. It's a one-way street.
Or we hope it is,
and we very much hope it stays a one-way street,
right.
Yes.
Now, in this series, Dr. Raju uses some specific navigation terms. I think we need to define them now, or the rest of this is going to sound like a foreign language. He talks a lot about proximal and distal.
These are the cardinal directions of anatomy. The best way to think of it is like a river. Think of the flow of food. Proximal means closer to the source, closer to the start.
The mouth being the source.
The mouth is the source. Distal means distant, or, further down the stream. So the esophagus is proximal to the stomach because it comes first.
And the stomach is distal to the esophagus.
Exactly. When you're moving an endoscope down a patient's throat, you are moving distally. You're traveling downstream.
Got it. That helps a lot. And then we have the standard 3D mapping terms. Anterior is front, posterior
is back, right? Superior is top, inferior is bottom. And we need those coordinates because this thing isn't just a straight pipe floating in a vacuum. It actually crosses 3 distinct zones in the body.
A traveler crossing borders, what are the zones?
Okay, so it starts in the neck. That's the cervical esophagus. Then it dives down past the first rib into the chest cavity. That's the thoracic esophagus.
Okay.
And then finally, it has a very short run in the belly after it punches through the diaphragm. That's the abdominal esophagus.
And those borders are actual physical structures, the rib, the diaphragm.
Oh, yes. The first rib separates the neck from the chest. And the diaphragm, that massive parachute-shaped muscle we use to breathe, is the literal wall between the chest and the abdomen. The esophagus has to pierce right through it.
All right, so we have our map. We're moving distally from neck through chest to belly. Now, let's talk about the real estate. I mentioned this is a high-rent district. The esophagus is jammed in there. Who are the neighbors?
This is where the anatomy gets stressful if you're a surgeon. The chest cavity is packed. Let's look at the anterior neighbors. What's sitting directly in front of the esophagus?
I call these the noisy neighbors.
Very noisy. First, in the neck and upper chest, you have the trachea, the windpipe.
So your breathing tube is right in front of your eating tube.
They're touching. Then, as you go lower, the left bronchus, which is the main airway to the left lung, and then sitting right in front of the lower esophagus is the heart, specifically the left atrium.
The heart. So the esophagus is literally tucked behind the beating heart.
Directly behind it. In fact, if you're doing an ultrasound from inside the esophagus, you get an incredibly clear view of the heart because there's nothing in the way. They're roommates.
Wow.
The esophagus basically gets a constant massage from the heart beating against it.
That's a vivid image. And if that wasn't enough pressure, what about the posterior neighbors? What's supporting it from the back?
It's a hard place, literally. You have the rigid column of the spine, the vertebrae, and running right alongside the spine is the aorta.
The main artery for the whole body.
The main high-pressure artery, yeah.
Okay, let's just pause and visualize that. You have this soft, muscular tube. Behind it, you have the spine and the massive aorta. In front of it, the windpipe and a beating heart.
It is in a very, very tight squeeze, and that vulnerability is key. When you're doing a procedure in there, you are operating millimeters away from the body's most critical infrastructure.
The stakes are incredibly high.
A perforation, a little hole, isn't just leaking into a cavity. You're risking damage to the heart, the lungs, the aorta. It's a minefield.
It's not just plumbing, it's bomb disposal. Okay, so now that we appreciate the danger, let's get in the car. We're shifting to the endoscope view. Dr. Raju emphasizes you don't just drive in.
No, it's tricky. You can't just shove a scope in. You have to navigate the throat. As you come down, you pass the uvula, then you see the larynx, the voice box, you see the epiglottis, that little flap, and the vocal cords.
And you do not want to drive the camera through the vocal cords.
Definitely not. That's the airway. The patient will not like that. You have to find the side entrance. There's a little pocket to the side of the voice box called the piriform fossa.
Piriform fossa sounds like a secret passage.
It functions like one. It's like a little slip road. You slide the scope tip into that pocket, then you turn towards the middle, apply a little pressure, and that pushes you through the upper esophageal sphincter, the UES.
A secret handshake to get into the club? Okay, we're in. How long is this road?
So Dr. Raju gives us the standard measurements for an average adult male in the U.S. From the lips, call that mile marker 0. It's about 15 centimeters just to get to that upper sphincter.
15 centimeters just to get in the door.
And then to get all the way down to the lower sphincter, the gate to the stomach, it's about 40 centimeters total from the lips.
40 centimeters, about
Yeah.
16 inches. Okay, so we're driving down this tunnel. What does the scenery look like? What are we seeing?
This is the visual transformation. The lining of a healthy esophagus is this beautiful, pale, light pink color. It's smooth.
Kind of like the inside of your cheek.
Exactly like that. But as you get to the bottom, that 30-centimeter mark, the terrain changes instantly.
What happens?
You hit the stomach lining, and the stomach isn't pale pink. It's described as beefy red or salmon-colored. So you get this very stark, high-contrast border where pale pink meets deep red.
And that border has a specific name, right?
It's one of the most important landmarks in the whole GI tract. It's called the Z-line, or the more technical term, the squama-columnar junction.
Let's unpack that. Squama-columnar, that's describing the two different types of cells.
Exactly. Squama refers to the squamous cells of the esophagus. They're flat, like tiles. Column refers to the column-shaped cells of the stomach. So the junction is where the tiles meet the columns.
And you call it the Z-line because it's zigzagged.
Yeah, it's not a ruler straight line. It looks like a jagged coastline on a map.
So, in a healthy person, this Z-line should be right where the stomach begins.
Ideally, yes. And this is the diagnostic insight Dr. Raju provides. When a doctor is down there, they are looking at the relationship between three specific things.
What are the three?
First, they find the Z-line, the color change. Second, they look for the gastroesophageal junction, which is the top of the stomach's wrinkles, the gastric folds.
Ah, right, the accordion folds.
Exactly. And third, they look for the diaphragmatic hiatus. That's the physical pinch point where the diaphragm muscle squeezes the tube from the outside. You can actually see it narrow when the patient breathes in.
So you have the color change, the texture change, and the physical pinch.
Right. And in a normal anatomy, those three things should all be roughly in the same neighborhood. Within a centimeter or two, they line up.
And if they don't, if the Z-line is way higher than that pinch point.
That is the aha moment.
Yeah.
That tells the doctor you might have a hiatal hernia where the stomach is slid up into the chest. Or, if that Z-line is irregular and creeping upwards, it could be Barrett's esophagus.
The precancerous condition from acid reflux.
Yes. The acid is literally burning the pink lining and turning it red. So measuring the distance between those three landmarks is how they diagnose the structural health of your plumbing.
It's all just geometry.
If the math is off, there's a problem.
Okay, I want to drill down a bit deeper. We've looked at the length, the landmarks, but what is this tube made of? Is it just skin?
It's much more robust. Dr. Raju breaks the wall down into 4 distinct layers from the inside out. Think of it like a house wall. You have the paints, the drywall, the wiring, and the studs.
Okay, let's peel it back. What's the paint, the inner layer?
That's the mucosa, the pink lining. In the esophagus, it's made of those squamous cells, the flat ones. They're stacked in multiple layers, almost like armor plating.
Armor? Why armor?
Friction. I mean, think about what you swallow. A crunchy piece of toast, hot coffee. The esophagus is a transport tube. It takes a beating. Those cells are built to handle it.
But the stomach cells are different.
Totally different. The stomach has columnar cells, single layers of cylinders. They aren't built for friction. They're built to secrete acid and absorb nutrients. That's why the Z-line is so dramatic. You're switching from an armored tunnel to a chemical vat.
Okay, that's the wallpaper. What's behind it?
Layer 2, the submucosa. This is loose connective tissue. I think of it as the utility crawl space. It's where the blood vessels, nerves, lymphatics, and glands all live.
An infrastructure.
Exactly. But the tube has to move to push food down.
Right.
The engine is layer 3, the muscularis propria, the muscle layer. And it's clever. It has 2 sublayers, an inner circle of muscle and an outer longitudinal layer.
Like a woven basket, maybe?
A bit, yeah, but it functions more like a snake. The circular muscles squeeze behind the food, and the longitudinal muscles shorten the tube to pull the food down. That creates the wave peristalsis.
And the final, outer coating.
Layer 4. And this is a crucial distinction Dr. Raju makes. The esophagus is covered in adventitia. It's a loose connective tissue that acts like Velcro. It binds the esophagus to the trachea, the spine, the aorta. It anchors it.
Okay, but doesn't every organ have that?
No. And that's the key. The stomach and the colon, they have serosa. Serosa is a smooth, slippery membrane that lets organs slide against each other in the belly.
So the esophagus is glued in place, but the stomach is slippery. Why does that matter to me?
It matters hugely if you have cancer. Because the esophagus lacks that slippery serosa barrier, it's easier for a tumor to spread directly into those neighbors we talked
The
about.
trachea or the heart?
Exactly. It spreads faster because there isn't that containment wall.
Right.
And it also makes surgery harder. The esophagus doesn't hold stitches well. It's fragile. It tears easily.
That's a fascinating detail. It's just structurally more vulnerable.
And when they do an endoscopic ultrasound, they can see all 4 layers as these black and white rings. They can stage cancer right there. They can say, okay, this tumor is only in layer 1, or this is punched through to layer 3. It determines everything.
Incredible. Okay, we built the walls. Now, the plumbing. How does this organ stay alive? It needs blood.
It does. And the blood supply it's a bit chaotic, honestly. The esophagus is so long, it can't rely on one artery. It's a scavenger. It steals blood from wherever it can along its route.
It takes what it can get.
Pretty much. The upper part gets blood from the thyroid arteries. The middle part gets branches right off the aorta. The bottom part gets blood from arteries in the belly. It's a patchwork grid.
Okay, so that's the inflow. What about the outflow, the veins? You said there was a bypass system.
Yes. The veins are where the story gets really interesting. This is a hidden superpower, or a hidden danger. The upper part of the esophagus drains normally back to the heart via the superior vena cava,
The main highway.
the main highway. But the lower esophagus drains into the portal vein,
And the portal vein goes where?
to the liver, for filtering. So right there, you have a connection between the main body circulation and the liver circulation.
Okay, so why is that a bypass?
Imagine you have liver disease, like cirrhosis. The liver gets hard, like a rock. Blood coming from the intestines can't get through. It hits a roadblock. It needs a detour.
So it backs up, and it finds the esophagus.
Exactly. The blood is forced backward, and it floods into those little veins in the lower esophagus. It uses them as a bridge to travel up the tube and dump into the vena cava, bypassing the liver entirely just to get back to the heart.
So the esophagus basically sacrifices its own veins to save the body's circulation.
It acts as an emergency relief valve. The problem is those esophageal veins aren't designed for that pressure. They swell up and become varices, fragile, overfilled balloons right inside the tube.
And if they burst,
If one of those bursts, it is a life-threatening emergency. Massive bleeding.
that connects the dots. I've heard of esophageal varices, but I never understood the mechanics. It's because the esophagus is the bridge between the two systems.
Precisely. It's a crucial vascular bridge.
Huh.
In a healthy person, it's just drainage. In a sick patient, it's a lifeline under immense, dangerous pressure.
It really changes how you visualize the body. It's not just independent parts, it's all one hydraulic system.
And Dr. Rogers' main point is you can't separate the anatomy from the pathology. You learn the layers to stage the cancer. You learn the veins to treat the liver patient. The map, the diagnosis.
So let's wrap this. We've traveled 40 centimeters of pink tubing. We've seen it sandwiched in a terrifyingly tight spot between the heart and spine.
No room for error. We've also seen the zigzag border war at the bottom where it meets the stomach.
It's a lot of complex machinery just to get a bite of a sandwich down.
It is. And I'll leave you with this final thought. We think of the esophagus as just a gravity chute, right? A simple pipe. But when you look at that venous connection, you realize it's actually a sophisticated interface connecting the pressure systems of the abdomen and the chest. It's doing so much more than just passing food.
A hidden hero in our plumbing.
Yeah.
Well, that brings us to the end of this deep dive. Next time you feel a little heartburn, remember the complex neighborhood going on inside your chest.
And appreciate the engineering.
Always. Thanks for listening, and we'll catch you on the next deep dive.